So my name is Meg Parker. I'm a neonatologist. I work in Boston as well. I work at a hospital probably a mile away from Lawrence called Boston Medical Center, which is the same one that Anne is affiliated with and the CHAMPS team. It's a safety net hospital. We've definitely had a lot of COVID at our hospital. But I will be talking to you today from my hat as one of the leaders of our Neonatal Quality Improvement Collaborative of Massachusetts, where I've been actively involved with hospitals all across our state that have really had to come to grapple with these rapid changes in their obstetric and newborn care practices. And just to be completely honest, for this presentation, I focused more on the neonatal side than the OB side, just because that's been my background and the role that I've been predominantly playing so far. Next slide. So normally our NeoQIC collaborative, we do statewide quality improvement where we have teams work together. And we actually have 3 active projects going on right now, including perinatal opioid use, respiratory care, and family engagement and disparities. But we actually had to put all of these on hold. And so we've switched gears. And in the last 2 months or so, we've had all of our efforts really focused on supporting teams through the COVID-19 pandemic. Next slide. So there you go. We've been working on perinatal support for COVID-19. Probably just like you all, we've been having webinars about every 2 weeks. The content of these webinars has focused a lot on hospital sharing, like what they've been doing, feedback they've received, just so people can sort of feel this sense of camaraderie of the state of how we're getting through this together. We also have expert speakers to speak on particular topics. And we review the literature and the professional guidelines, which Lauren alluded to. As we all know on this call, there's been some discrepancies in some of the recommendations by different professional organizations, and we've been really trying to make those differences clear so that hospitals can make their best informed decision about what they would like to do as a group. We've also done a couple practice surveys. I'm going to show you some highlights of those. They're obviously available on our website if anyone wants to take a look too. And we've done some aggregate data level data collection. Next slide. Next slide. So as I was saying, we've had 2 different, let me just close this down so I have more space. There we go. We've conducted 2 different practice surveys within hospitals in our state addressing obstetric and newborn care practices. The first one you can see we did in the very beginning of April, and the second one we did in the very beginning of May. And so we definitely noticed some changes in the results between the first and the second one. So this is probably the most dramatic change we saw, is that in early April, when we asked about testing of women that presented to labor and delivery that were expected to deliver, you can see when we first started, 93% of the hospitals that completed the survey were testing mothers based on signs and symptoms. But a month later, we're up to 84%, or nearly all, switching to universal testing. And again, as Lauren alluded to, a big push and a big driver for that was actually that study that came out of New York talking about the high rate of asymptomatic women. Next slide. This was another thing, what you guys, I'm sure everyone's been dealing with this too, is how do we approach visitation and support persons? And in our most recent survey, we did see that all of the hospitals have restricted to only 1 support person being there for mothers on labor and delivery. Next slide. Now, this is probably the most controversial topic that has come up in this whole perinatal COVID-19 care practice arena, which is about the location of care for mother-infant dyads. As we know, there's been different conflicting recommendations. So what I'll highlight here when we asked about where location of care is occurring is that you can see in that big circled part up there, you know, it looks like about 40% in survey 1 and about 20% in survey 2 are having their default practice being to separate mothers and infants. But the majority of hospitals in Massachusetts, looking at like 40 to 50% or so, both in early April and in early May, are basing this decision on the shared decision-making model on a case-by-case basis, which was the language that was promoted in the CDC guideline as of until late last week anyhow. And I would say probably based on the same things your hospitals are grappling with or in Mississippi is that a lot of times this decision has been based on practical reasons, like literally just not having the space to separate mothers, in conjunction with just teams' feelings about this topic and really wanting to keep mothers and infants together because they believe that's the best approach, and they believe that mothers should have the ability to make that decision jointly with their providers in the backdrop of us really not knowing too much about transmission of COVID-19 to neonates at this time. Next slide. What is your approach to skin in the first hour after birth? So you can see here that both in survey 1 and in survey 2, the majority of respondents are not allowing that, either prohibiting it or discouraging it. Next slide. Now with respect to delayed cord clamping, this was fairly interesting to me. It looks like about 40% in both survey 1 and in survey 2 of our hospitals are not performing delayed cord clamping. This was an interesting one because it's something that's actually not been promoted as something we should be doing in like any of the recommendations out there from professional organizations. So something that teams have started to adopt without a lot of indication that this is something professional societies are recommending. Next slide. Early baths, you can see that it was up to 2/3 in survey 1 and up to above 80% in survey 2 of hospitals are moving towards early baths per professional recommendations among babies of mothers that are COVID-19 positive. Next slide. Now the approach to direct breastfeeding for those on the call particularly interested in that practice. So in both of our surveys, you can see that in survey 1, rather, direct breastfeeding was encouraged with precautions, was 60%. And then in survey 2, we did delineate this a little bit more, where we had 1/3 say direct breastfeeding was encouraged with precautions, and then we kind of changed the wording of the question. We saw 62% of hospitals agree with the statement, direct breastfeeding is discouraged but permitted if the family strongly desires. Next slide. What's your approach to testing of newborns? Was interesting in Massachusetts, we had, it was a minority, 12% of hospitals in both survey 1 and survey 2 said that they still are not testing infants, which I found interesting. And I'm curious to see what partners in Mississippi are doing about this. Generally speaking, our hospitals do have access to doing newborn testing and have been doing it. Hospitals varied in the number of tests. Most are trying to do 2 or more tests depending on how long the baby stays in the hospital. Next slide. The last question is about discharge care processes. These are really important to consider because there's a lot of different things that go into testing of newborns before discharge. So we asked about whether or not these processes have changed at all. Next slide. And the ones that appear to have changed the most were circumcisions and hearing screens. So you can see a large number of hospitals have moved towards moving these circumcisions to the outpatient time period. And some institutions have also moved hearing screening to the outpatient time period. Next slide. Oh, and I just wanted to show you, oh, that name is incorrect there. I just wanted to show you some aggregate data that we've collected so far from our centers. And this was all really voluntary. Next slide. So there's various different ways newborn and obstetrical data is being collected across the US. And this was just our local team sharing with our NeoQIC organization some basic information about what has happened so far. So last week we presented this, and this is the data that we've gotten so far. This is the number of newborns born to a COVID-19 positive parent. And this just represents a subset of the hospitals in our state, but you can see there Beth Israel, Boston Medical Center, Brigham and Women's, and Mass General are the sites that have the largest number of births. The one not there is probably UMass Memorial and Bay State, which are in western portions of the state. So hopefully we'll have their data next. But this gives you a sense of the general numbers of COVID positive parents that we're seeing, predominantly mothers that we're seeing so far. Next slide. Some demographics on the infants. You can see probably the most telling part there is we're seeing 19% of them born at 32 to 35 weeks and the very high C-section rate. While we don't know too much about why that's happening so far, what I've seen, at least that I can comment on at my own center, at Boston Medical Center, is that a lot of these women can be quite ill. And therefore they're having C-section deliveries early, or they're having inductions early. There's a whole variety of things, but generally these mothers are sick, and so therefore their delivery outcomes represent that. Next slide. In terms of location of care, this is looking more objectively at the cases that people reported on so far. You can see that 38% say that they're having the baby stay with the mothers for the entire part of the hospitalization. 16% say the same room as the mother for only part, so meaning part of them they were probably together and then got separated later, and about half say they're separating from the mother throughout. Among the separated, you can see the vast majority are separated because of a hospital policy related to this. Next slide. In terms of breastfeeding, this was how our aggregate data looks so far, that about a third of these babies born to COVID positive moms are not receiving any milk during the hospitalization. I can't tell you more detailed reasons about that at this time. I suspect some of that may be just because these mothers can be very sick when they deliver. About a third are receiving some express milk from their babies, and you can see 45% of the infants did have some direct breastfeeding. Next slide. In terms of the COVID testing, so far in this relatively small numbers, we've had 6% of the babies become positive. It actually turns out all of those positive babies have been from my own center at Boston Medical. We've had 5 positive infants, which is higher than anywhere else so far that we know about in the state. Next slide. Yep, I just wanted to wrap up with a couple brief things. I know we don't have a lot of time and happy to chat later. One thing that we're launching right now is a national COVID-19 newborn practice survey. It's very short, it's 5 to 7 minutes long. Our goal is to understand regional variation. We just opened it up yesterday, and it'll be open for a week. And we're very happy to provide aggregate data at the state level to Mississippi hospitals, for example, if you are interested in seeing what is happening there. I recognize that Anne is going to present what you guys have done, but if anyone is interested in seeing this a second time and what's changed, very happy to give you that. And that's the RedCamp link, and we can provide that afterwards. Next slide. And I think that's it. I'd be happy to take any additional questions people have about what's happening in Massachusetts or even at Boston Medical Center.